Welcome, everyone. Thank you for joining us today. We are going to get started this morning or this afternoon, depending on where you are, with a short video about the American Association for Cancer Education. And then I'm going to go through just a couple of rules of engagement for Zoom, and then we're going to get started with our program. So hopefully you will be able to hear my video just fine. I did share my sound, so hopefully this will go well.
I joined AACE in 2008 when I was a postdoctoral fellow at Moffitt Cancer Center at the urging of my mentor at the time, Dr. Kathy Mead, since the annual meeting was to be held in Clearwater Beach, Florida. We organized a panel at that conference on barbers as prostate cancer health educators. We published findings from this prostate cancer education study in the Journal of Cancer Education, or JCE. And since then, I've continued to publish my research in JCE. And a few years ago, I was invited to join the editorial board. In 2016, with my colleague, Dr. Levi Ross, we co-edited a special issue of JCE on cancer prevention and control in African Americans. I first served on the ICEC Conference Planning Committee in 2014 and joined the Executive Council first as a member at large in 2018, and I'm now currently serving as Secretary of the organization. It has been a great experience getting to know fellow AACE members through the annual conference and by serving on the council. It has helped my career by serving as a regular reviewer of the journal and participating in the annual conference to hone my skills as a cancer education researcher.
Okay, thank you for enjoying that with me. So sorry for that in your ears. I'm trying to find my slide control again here to get to the next slide. Well, you know what? I might just have to escape out of it for a second. Start again from here. Apologies for the delay. Anyway, I'm just going to say welcome. Welcome, everyone. We're talking about early onset colorectal cancer today. And we are partnering with the Virginia Colorectal Cancer Roundtables. There we go. And we are really glad that you are here with us. So I just want to go over a couple of rules. Number one, we are recording. So if you decide to speak out loud, be aware of that fact. We're also live streaming to Facebook and YouTube right now. So hello to any of our live stream viewers, and just a thing to keep in mind. Please rename yourself if necessary. If your Zoom has pulled you in as some odd name or the name of your device, so that if you want to speak, we know who we're speaking with. Stay muted when you are not speaking. And if you want to speak out loud, and we have a lot of people wanting to talk, please raise your hand and we can help you unmute. so that you can talk. You can also use the chat window if you'd rather type your question. And if you have any technical issues, go ahead and chat directly to me, Jen Aloisi at AACE HQ, and I will help you with your technical issues. And with that, I'm going to go ahead and stop sharing and hand this over to Dr. Michael Preston to introduce our panel and get us started.
All right. Good afternoon, everyone. I'm Michael Preston. I'm an assistant professor at Virginia Commonwealth University, and also am a co-chair of the Virginia Colorectal Cancer Roundtable, along with Dr. Cindy Yoshida. And so my job here is I'm your host for today. So I'm just going to go through our goal for today is to increase awareness of early onset colorectal cancer and discuss strategies for addressing early onset colorectal cancer through a multi-modality approach. And with that, after this session, you should be able to identify potential risk factors and causes of early onset colorectal cancer, understand the current guidelines and modes of screening for colorectal cancer, and also be able to describe strategies that can be used to improve timely colorectal cancer screening. So what I'm going to do first is kind of introduce our dynamic group of speakers for today. They are very well known in this field, in this area. The first person I would like to introduce you to is Dr. Whitney Jones. He's going to talk to you about risk factors and trends in early onset. I'm going to read his bio, and then I will allow, I'll read everybody's bio, then I'll allow each one of them to provide, the information that they're going to talk about today. So Dr. Whitney Jones is a gastroenterologist. He's a former therapeutic endoscopic and clinical professor at the University of Louisville. He's currently an adjunct professor at the University of Louisville School of Public Health. He's also a member of the Kentucky Colon Cancer Screening Program Advisory Committee and serves as the chair of that committee. He's also founded a nonprofit 501c3, the Colon Cancer Prevention Project, which is a leading colorectal cancer information and advocacy organization focused on innovation, acceleration of evidence-based screening through emerging biotech and logistics. He's also been one of the person that has led a lot of legislative work in Kentucky and has now, I guess Kentucky has the distinguished, designation as one of the states that has the lowest barriers for colorectal cancer screening in the nation. So we will welcome Dr. Jones to this panel. The next presenter is going to talk about making a move from 50 to 45 years of age. Dr. Alice Chris, our very own at Virginia Commonwealth University. He's a practicing family medical physician. He also teaches resident physicians at VCU Fairfax Family Medicine Residency and former vice chair of the United States Preventative Services Task Force, independent volunteer panel of national experts in prevention and evidence-based medicine. He is the co-director of the Community Engaged Research at VCU C. Kenneth and Diane Wright Center for Clinical and Translational Research. We also have Hitting Cancer Below the Belt Junior Board. They're going to talk about engaging our youth in the conversation around colorectal cancer. So HCB2's Junior Board consists of Richmond area high school students interested in learning about colon health and helping to prevent the early onset of colorectal cancer. The Junior Board members identify content, create infographics, and promote their messages using various methods to better reach the Generation Z community. And last but not least, we have Dr. Reed Davis. He's a third-year resident at UVA Health, and he's going to talk about engaging the next generation of healthcare providers. His he is a third-year internal medicine resident at UVA. He was born and raised in the South Mississippi and is returning there in July to practice academic primary care. Professionally, he loves disease prevention and chronic disease care. At home, he loves chasing his 1.5-year-old with his wife and finding the best barbecue in the area. So again, welcome. Thank you all for being here. And we're gonna start with Dr. Jones. You have the floor.
Great, thank you very much. And I'll just give a nod to my guys when it's time to change. So first of all, thank you very much. I'm honored as your neighbor to be here and to talk with the great folks of Virginia. We share some common borders, we share some Appalachia. And today I'm gonna give you guys a whirlwind tour to where I see the vision of early onset colon cancer. And in this picture, we see Stan Lee, who started Marvel Comics, and we see Chad Boseman, who died of colon cancer in his early 40s after developing it at 38. And so I think this is the perfect juxtaposition for the old communication strategy, where guys like Stan Lee have probably heard the message around colon cancer screening more times than they want to know. And unfortunately, probably Chad Boseman never once heard the story about colon cancer screening before he presented with symptoms and was evaluated. And so what we really need is adaptive approaches and complementary, not competitive to the current messaging strategy that we've looked at and leaned on for the last couple of years. So next slide. And really what I hope to do by the end of the day is convince you guys that as we attack overall colorectal cancer mortality in your state, one of the drivers and one of the things that will slow you down more than anything is not paying attention to this massive change in colorectal cancer incidence under the age of 50. So to really drive your overall colon cancer mission in Virginia, early onset colon cancer is a part of it. Next part. These are my disclosures. Next slide. So this is where it all really started. You can hit the button one more time. And this was data that came out about 7 or 8 years ago by Rebecca Siegel. And below the red square, you can see all those curves moving down. And that's essentially age 55 and over. So starting at 55 and over, we were making great strides in reducing the colon cancer incidence and deaths from colorectal cancer. But in the box are units of time between 20 and 54 years of age, where you can see these curves, unfortunately, are increasing in their incidence of colorectal cancer and more steep in the younger population, but even breaking through to 50 and 54. And you might say, well, why are these 50 and 54-year-olds still having increases risk of screening? We told them at 50 to get screened. And the graph on the left shows that the folks who are 50 to 54 are not nearly as likely to be screened as those as we get older. And in the bottom two, you can look at the red, which probably represents people at high risk for colorectal cancer based on family histories of polyps and cancers. And in the blue, the folks who are, age 45 to 50. And again, I know that's going to be a part, but colon cancer is changing. We have to dramatically change our results. The reason you guys are all here today is that you got information about this conference months and weeks and reminders in advance. And really getting people screened on time is going to be one of the critical messages that comes out of this talk today and this symposium. So if it's important enough to get it done, it's important enough to get it done on time. And those are the strategies we'll talk about. So it's really not going to be about statistics as much as about the logistics of how we inform people about young colon cancer and how we get them to their appropriate screening on time. Next slide. And now one of the great things we don't have to talk about that we did for the last 5 years is the difference between states and their screening age. And if Virginia followed ACS screening guidelines, then you guys have had over 3 years to be ramping up your 45 to 50 screening routes. And again, that's complicated by insurance issues and coverage. But I think nationally, we're collectively engaged at this average risk colon cancer screening now starts at age 45. And so the race is on, not to have that out there, but to begin to implement it. Next slide, please. And so this is a little data from your neighbor. And we've been studying early age onset colon cancer for some time. And being that we led the nation in incidence and mortality for quite some time, and we knew colon cancer in young ages was important, this graph shows Kentucky in the red and our under age 50 colorectal cancer incidence, which is going up dramatically. And then that compares this in the blue. And if you can hit the clicker one more time, you can see that the nation is going up, but Kentucky started at a higher rate, and we're actually expanding this difference. So part of what's driving Kentucky's colorectal cancer rates is, in fact, this early age onset colon cancer. And if you'll hit the next slide, and it isn't just that we have it, we know where this is. This is in our Appalachian region. And in the red, you'll see our Appalachian under age 50 colon cancer rates, which are increasing. And we're comparing that to the non-Appalachian colon cancer rates, which are increasing, but not to the same degree. And if you'll click that one time, it just shows these are dramatically statistically significant. And so knowing where your young colon cancer is in your state, and I would argue it's probably going to be in Western Virginia or your Appalachia, as well as in some of your urban areas. And African Americans have had high rates of early age onset colon cancer for quite some time. And this trend that's been happening for over a decade now is really affecting non-African Americans. And again, talking more about where that cancer is located. Next slide. But before we get to that, these are the top 10 states in the nation. And in fact, the top 20, if you include both sides. And that's really just a combination of the incidence and the mortality of colorectal cancer. And then on over here on the right side of each of these is their national rank for early age onset colorectal cancer incidence. And what a surprise that out of the top 8 states with colon cancer incidence, they are also in that under age 50 route. And when you look at the 7-10, 11 through 20, 7 out of those next 10 states are also in those for early colon cancer. So I think this goes on to just support the fact that colon cancer in its youngest ages is what's impacting our overall cancer burden. And the good news is I don't see Virginia on either of these slides. Next slide. So this is a paper out of Cancer in 2020 that sort of looked at how are we communicating colon cancer and getting screened on time? Because we know that colon cancer was going up between 50 and 55. And it's because if you tell someone at 50, it's going to take them multiple years. So what we proposed was assessing people's risk at 35 and then really figuring out how many times you have to tell a person about colorectal cancer screening before they're going to get the study. And for familial risk, those at the highest risk who need to be screened at 40, maybe it takes 4 to 7 interactions, but you have to start assessing early and messaging early. And likewise, for average risk, the same concept. You cannot start telling people they need to be screened at the date you want them screened. It doesn't work. You have to have a better logistical plan. Next slide. And when we look at young colon cancer, what you've got to realize is though about 60 or 70% of it is sporadic. People don't have a family history. So if you want to educate them about the symptoms of colon cancer, which are going to come out of nowhere, you have to start educating them earlier, because right now there's a 3 to 12 month hiatus between the time a guy has symptoms or a woman has symptoms and they go to the doctor's doors. And because doctors aren't fully educated about this increasing epidemic, if you will, they also delay that. So our goal down the road, next slide, is to switch that delay from weeks to months. And that's through education of the population from their 20s up into that average risk screening time, as well as education of physicians. Next slide. And so we've invested heavily really in this normal risk screening paradigm through education. We've not educated very strongly in this high risk screen because we've not, as a rule, educated people in their 20s and 30s about getting screened on time. That's really more opportunistic, I would argue. And so if you'll hit the next slide, what we really need to do is add what we call the early messaging package, which is starting to educate people about 3 particular areas. Number 1, the evaluation and identification of symptoms. So regardless of their age, when they develop these, they come in to have a minimum delay. Number two, about family history. If colon cancer runs in your family, polyps, syndromes like Lynch syndrome or familial polyposis are all critical. And again, about 1 in 5 to 1 in 4 people need to be screened at 40 or sooner based on their family history. If we're not talking to people about this until they're 45, we've missed our window of opportunity. And finally, lifestyle modification. Eating vegetables, eating good food makes great sense, but it doesn't help that much once you're 50 or 60 or 70. It has its greatest impact when you're young. And we cannot just talk about this. We have to invest in our messaging package financially. And again, I think the great benefit of messaging people lifelong is that we're more likely to find these high risks as well as get normal risk individuals screened on time. Next slide. And so in Kentucky, we have integrated under age 50 colorectal cancer into at least 5 of our 6 core messages. And so when we message in Kentucky, it has to fit into one of these buckets. You can't give all the messages on any one ad or any one moment. But again, thinking about if your average risk, 45 is the new date. Family history and polyps or cancer, 40 or earlier. If you have symptoms, no matter how old you are, get to your doctor or healthcare provider. And 5, it's not your grandpa's disease anymore. You need to get a heads up on this. And so this is integrated into our messaging on all platforms. Next slide. And so here's just a few examples of what we've done. In early last year, we delivered over 3.5 million digital ads that you see on the right here. And they were all about things that young people are in on, right? Basketball, hunting, fishing. We have urban messages. We have Hispanic messages. We have messages in Espanol, hablamos Espanol. And again, this overlying message. And then this is an Appalachian piece of a piece we call, which is preventing colon cancer through your life. This is in about 17 states and 4 countries. And you can add your local information here to this, but it basically uses different messages. We have an urban message, a Hispanic message, and a rural message, but we integrate 4-wheelers. We integrate hot dogs. What's a family history mean? Don't smoke, get your weight right. Know your family history and use genetic testing when appropriate. Know those symptoms early enough. And again, really doing that information, doing that education so that 45 becomes the finish line for our educational process, not the starting point. And so I think this really rolls in to that logistics mindset. Next slide. And so the challenges that you face in Virginia and we face here around this, as well as cancer generally, is number one, the number of missed opportunities because of COVID. And really what we are doing in Kentucky is encouraging hospitals and health systems to data mine and bulk order take-at-home stool tests to overcome some of these. I think people who are not up to date in the medical record between 45 and 49, as well as above, they're fair game to use choice architecture and your screening architecture to reach out to them now to give them something as a take-it-home option while the system's catching up. And this includes payers, health systems, providers, your Department of Public Health. And if you're like Kentucky, it'll be your pharmacy groups that'll be educating folks pretty soon. Number 2, you have 300,000 Virginians between 45 and 49 who are now eligible. And again, you need to engage the all of the above system in screening, not be focused on just colonoscopy or structural exams, and work with your health systems, your providers, education, and think about how do you develop a logistic program to bulk order and get these tests out now. And again, those high-risk people between 45, you have 275,000. And those younger guys where you want to start your educational practice, about 250,000. And finally, leave no group behind. We've got to have interventions for disparate populations, whether that's rural, whether that's urban, whether it's personas hablan español. It's important that we develop early and more frequent messaging in languages and ways that they understand to get to those folks, to get their messages out so they can get on-time screening. Look for opportunities within the community health center region as an opportunity to develop projects and reach some folks. And again, I think Virginia is a lot like us. You're going to need an urban message and a rural message to reach all these people. Next slide. And so as you look at screening, think about building a war. Because if we talk about the war on cancer, let's talk about castles, right? We're going to build out here way far in advance with people in their 20s, early onset colon cancer awareness, better diets. And yes, those are 2 tacos in case you're interested. Eat well, don't smoke, get the weight right. As you move further on in there, we want to pick out those high-risk people with genetic problems and familial histories and get those guys screened at 40 or sooner. And by the time a person reaches 45, they will have heard multiple messages and be softened up for on-time screening. And so if this is a war on cancer and colon cancer and young colon cancer specifically, we've got to get a good logistical plan to deliver the messaging and the screening on time when it matters the most. So we're going to drop it off into the rest of the symposium here. I want to say thank you for your time, and it's great to be your partners. Everything we have in our state and Commonwealth, we're happy to share with you guys in Virginia. So back to you, Lindsay, and Michael, thanks so much. I look forward to the rest of the symposium.
All right. So thank you, Dr. Jones. We're going to move on to making a move from 50 to 45. Dr. Chris.
Great. I'm happy to be here today, and I'm hoping my internet connection will work well. I'm in a mountain in Utah. So, but I want to build on what Dr. Jones was talking about here today, and I'm going to focus on the U.S. Preventive Services Task Force recommendations. If you can go to the next slide. Dr. Jones had showed a slide how there had been some disagreements between American Cancer Society and U.S. Preventive Services Task Force recommendations, but there aren't any more. As of last year, the U.S. Preventive Services Task Force started recommending screening at the age of 45 as well. What you see is there's an A recommendation for screening at 50 and a B for screening at 45. For clinicians and patients, an A and a B means exactly the same thing. It means that it's recommended that you should routinely do something. The difference between the letters just has to do with sort of the strength of the evidence. The majority of the trials included people 50 and older, so there was stronger evidence giving an A, but that doesn't mean it's better to screen starting at 50 versus 45. We're going to talk about that, and you heard about that already from Dr. Jones. I want to point out also that right now, in terms of coverage, all insurers are mandated for what we call $0 coverage for A and B U.S. Preventive Services Task Force recommendations. That means it's recommended to deliver and cover these preventive services with no copays for patients. And this recommendation was updated more than a year ago, so that means that really this should be eligible for all patients. And then older patients, 76 to 85, it's a C recommendation, which means that there is evidence of a small benefit for screening in this population. And for clinicians and patients, this means engage in shared decision-making. So the patients that are healthy enough to undergo screening may want to, whereas patients who have other competing comorbidities may not want to. Next slide. Here are the 4 messages of the U.S. Preventive Services Task Force recommendation. The first one everyone here knows: screening saves lives, get screened. The second one is start screening at 45, which we heard Dr. Jones talking about. And there's data showing that colorectal cancer in a 45-year-old is just like that of a 50-year-old in the past. So the epidemiology has changed. The third one is there's several tests available, and they all work, and they all have different barriers and facilitators for getting screened. And thinking about what the best test is for each person is the best approach here. And then the last one, which you started to hear a little bit about, is that Black adults get colon cancer more often, and they're more likely to die from colon cancer. So it's particularly important to think about screening in these communities. Next slide. Here are the 4 recommended preventive services for colorectal cancer screening. So you have your stool-based test, and that's like your FIT test looking for microscopic blood. And then you have your stool plus DNA test. And then you have your visualization test, the virtual colonoscopy, the flexible sigmoidoscopy, and colonoscopy. As a family physician, I primarily offer my patients the FIT test or colonoscopy, just because those seem to accompany the different barriers and allow me to get the most of my patients screened. Although certainly if people wanted a different test, I would offer that as well. Next slide. This is an important study that actually we conducted here pretty extensively in Virginia back in 2009. And it hasn't changed from a data standpoint. And these are patient-reported barriers to screening based on the test type. So, it's interesting when you look at that column on stool-based testing, the biggest barrier that people report is they didn't know that this was an alternative and a way that could get screened. They didn't know it was just as good potentially as the visualization tests in terms of saving lives. And then you look at the barriers for colonoscopy, and this is things like the prep and concerns about adverse, consequences or complications from the colonoscopy, which, while small, they are there, and a little bit more of the intrusiveness of the test. Next slide. This is something I want to show you that I think is important about Virginia, and I suspect that this is true for every state, and I think Dr. Jones was hinting at this as well. So what you see in the top is a heat map of screening rates for colonoscopy. Darker colors means you have higher rates of screening. Below, you see screening rates for stool-based tests by census tract throughout the entire state of Virginia. And what I want you to know is that in the green area, which is Northern Virginia, we see higher rates of stool-based testing. Still, colonoscopy is the primary screening rate, but there's greater penetration of stool-based testing. And we see in this community that there's actually lower rates of colorectal cancer death. In red, in kind of a central rural area of Virginia, we have both low rates of colonoscopy, but in particular, low rates of screening tests. And we also know that there's high drive times to colonoscopy centers, and that's where we have some of our highest colon cancer death rates. So really understanding local barriers and communities is an important thing to get at when trying to think about increasing colon cancer screening. Next slide. So let's talk about why 45. There are 3 reasons to move the age down from 50 to 45. There was a change in population prevalence trends. The original trials for the stool-based tests actually included some people under the age of 50, so that gave the task force confidence that the evidence would apply to this group. And then there's modeling that really demonstrates the benefit. Let me show you some of this data. Go to the next slide. I'm going to be super quick on this because you saw a variant of this. This was the risk of colorectal cancer by different age groups over time. As Dr. Jones said, in all of the groups, really 55, but even some 50 and older, you see declines in a risk of colorectal cancer and death from colorectal cancer. And the younger age groups, it goes up. And while in a group like 20, it is going up a lot, it does go up more as you age more, and that's where you see kind of these different levels here. But these trends led to the task force to confidence in lowering the age to start screening. Next slide. I encourage you for clinicians and folks trying to communicate this to patients and community members, look at the very bottom of the task force recommendation. There's some really great tables there that show you in the modeling the life years gained with screening, and it shows you the life years gained for each different screening method. And essentially what I want you to see is the same number of life years are gained for different screening methods. There's a little bit of a difference, for example, with the stool DNA test every 3 years versus the colonoscopy, but most of those are basically statistically the same number. And then you see on the right-hand side of this column that we're increasing the life years gained if we move screening down to a younger age of 45. Next slide. So people often ask, well, if screening at 45 is good, why not just start screening everyone earlier? And it has to do with the balance of the benefits and harms. So here's the number of lifetime tests by different screening regimens. And what you see is that moving that age to around 45 seems to maximize the benefits in terms of preventing deaths from colon cancer with not having too many excessive lifetime tests, which could have some potential complications or harms. Next slide. I mentioned here about Black adults, and it's important to know that Black adults have higher rates of colon cancer and death from colon cancer. The task force looked really closely at the data to say, could we make a different recommendation for Black adults, potentially say start screening at age 40? And sadly, there wasn't any data really to show that we should say something different for Black adults compared to other races and ethnicities. Next slide. We even went to the effort of trying to put in, even though there were no direct trials, we tried to put in evidence that we knew about access to screening and quality and timing and other factors into our modeling to say, okay, could we see a difference if we model a different screening regimen for Black adults? And we couldn't. But one disturbing finding that we found is that if you were to put in similar access to screening, well, we saw systemic differences for Black communities in access to screening, quality of screening, timing from diagnosis to treatment, and quality of treatment. And when we adjusted for all of those factors, the mortality differences went away. Next slide. What that meant from the task force perspective is that we thought the data was showing us that this is examples of how systems of care are adversely impacting Black communities. And the task force made explicit comments throughout its recommendations to ensure that Black people get screened starting at 45. It's particularly important. And then really to develop those systems of care to make sure that adults, Black adults, receive high quality care across that whole continuum of screening to treatment. And that's going to be our pathway for getting rid of some of these health inequities that we've observed. I'm going to stop here and make sure that we have time for questions at the end.
All right, thank you, Dr. Chris. We're going to move on to our next presenter, Hitting Cancer Below the Belt Junior Board.
Thank you very much, Dr. Preston, Dr. Christ, and Dr. Jones. Amazing, wonderful information. So thank you for that as well. I am Mindy Conklin. I'm the founder and executive director of Hitting Cancer Below the Belt. We're a grassroots nonprofit based here in Richmond, Virginia, but we serve the state of Virginia. Our primary focus is screening the uninsured and underserved population. So we actually fund screening programs across the state at medical sites, 9 different medical sites across the state. We also offer locally to the Richmond cancer patients nutrition support. And most recently, we've expanded our educational program. A couple years ago, we bought our large inflatable colon, but now we understand because of the early onset of colorectal cancer that we really need to expand our education program to the younger community. I started the organization in 2013 after my late husband passed away of colorectal cancer at age 43. He was 41 at the time of diagnosis. He has no family history, and he was the baby out of 7. And so that's a large family, and there is no family history. All his brothers and sisters are just fine. So still scratching my head over this one, but here we are. We have a junior board. I'm very excited to have them present to you exactly what they've been working on. I'm going to start with Eva and Juliet. They've really taken the lead in regards to creating just some general information about gut health. So Eva and Juliet, would you like to unmute and share your work?
Yes, hi, thank you for having us. My name is Eva, and this is my sister Juliet. We both go to Freeman High School in Henrico, Virginia. So we helped to start this junior board about a year ago in honor of our Uncle Gabe, who lost his battle to colon cancer at the age of 45 about 3 years ago. So we're now on a mission to help ensure that this awful disease does not take lives of the younger generation unnecessarily. So to that end, we are working on teaching teenagers the importance of gut health and how it impacts our overall health in general. Juliet, would you like to explain more?
Yeah, thank you, Eva. So about gut health, it turns out it's about a lot more than just when you're in the bathroom. It's actually linked to a lot of things that people our age care a lot about, like physical health and skin health, and a lot to mental health. And so we know that the relationship between mental health and the gut is a two-way street linked through the vagus nerve. So if you've ever had butterflies in your stomach, that's the vagus nerve. And it's basically whatever is going on in your mind. If your mind is in a good place, so is your gut. And, relay switching off. So the vagus nerve is also what makes you feel more confident and ready to take on goals and achievements of the day when you have good gut diversity and good gut health.
Thank you, Eva and Juliet. As you can see, as I've been meeting with these students since the end of 2021, they're very concerned about their peers' mental health. And so we're beginning to do a lot more research and education in regards to that gut-brain axis. And so I believe that's why Eva and Juliet both wanted to explore a little bit more in that area and share with you the work that they're just beginning to do. The actual promotional collateral and messages have not been identified and confirmed yet. So they do not have something to share with you on the screen at this moment. However, I am going to go ahead and move over to Sujan and Charlotte, who have created a very nice image that will be posted certain places around the school. And I'm going to go ahead and let Lindsay show the Let's Reflect flyer, and I'm going to let Sujan go ahead and take over.
Hi, my name is Sajan Allen. I'm a 17-year-old junior at Clover Hill High School in Chesterfield County. And I got involved with the junior crew at HCB2 because I saw that teens nowadays really eat a lot of unhealthy foods without taking into consideration the effect that that can have on their gut. So I wanted to raise awareness for gut health in teens in my generation so that we could live sustainable lifestyles and that our diets will prevent the uptick in different gut health problems. So this really ties in with our Let's Reflect flyer on the screen. And so we are planning to place these in school bathrooms next to the mirrors because we can really catch students' attention at that area while they're washing their hands, not distracted with their phones. And the title Let's Reflect has to do with both the positioning next to the mirrors and that their gut health mirrors their overall health, like our previous partners were talking about the vagus nerve. And so I'll now pass it over to Charlotte, who is more involved with the information portion of the flyer and how that pertains to youth today.
Thank you, Sujan. He said it exactly correct. Gut health does mirror overall health. And once we get that message across, what tools are we giving the youth to take action with this? Well, this Let's Reflect poster, as he said, that's going to be placed in schools' bathrooms, is a way for the youth to quickly check in and make some changes if they need to. So, and these changes, these solutions will thereby improve skin health, mental health, and the overall health of these teens. And so as the flyer infographic says, if you notice suffering from stomach aches, bloating, or nausea, it might be important to take consideration in a few simple solutions to your daily activity. And so some of these would be drinking more water, avoiding overly processed foods, consider taking a probiotic, and getting daily exercise, even if it's just a quick walk outside. These are all very important to a healthy gut system and therefore overall health. Like I said, these are just a few of the many actions people can take. There are many more that you could research and find out about. But with that, treating your body properly and taking care of your gut is very important at a young age to then have a healthy system along the road in your later years. Thank you.
Thank you, Sujan, and thank you, Charlotte, so much. As you can see, the students have identified issues that directly affect their peers. They've come up with that they hear that their peers and themselves have stomach aches. They hear their peers are having bloating, nausea, skin issues, mental health. So these are actually the aspects that they want to focus on in regards to bringing information into the schools and then raise the level of conversation about gut health and colorectal cancer prevention. The beautiful thing about the junior club is that most of these parents are of screening age, right? So we actually go to the high schools with our inflatable colon and we get to meet the parents and talk with the parents about the junior club and again, raise that conversation about screening and the screening age drop to 45. Family history and symptoms, that sort of thing is a large part of the type of education we do when we're out in the community. Lastly, I want to share with you Callie. Callie has been working on recruiting and marketing for our upcoming 5K. Go ahead, Callie.
Hello, I'm Callie Kennedy. I'm a freshman at Maggie Walker Governor's School. My aunt was diagnosed with colon cancer about 1.5 years ago, and I'm here to support her as well as contribute to defeating colon cancer and raising more awareness. So I'm going to be discussing the HCB2's Boxer Brief 5K. The junior board has been working to spread information about the 5K, and we have been advertising it through social media and flyers. This is actually the 10th annual Boxer Brief 5K. The flyer we created includes all the details about the race, including the date, which is Saturday, June 11th, the location at City Stadium, and more details about the purpose of the 5K. Also, the new high school challenge. The high school challenge is a competition between high school students to win money for their school. There are multiple awards, and the winners can choose a department like art, a band, a club, or a sports team to designate the money to. And this increases a lot more involvement among the youth, and it adds even more excitement. So the QR code is included at the bottom of our flyer, and it can be scanned to immediately sign up for the high school challenge with your specific school, and all the schools are competing. We're going to hang our flyers in halls and bathrooms around our schools so students can easily find out about the 5K and learn more and quickly sign up. And yeah, the Boxer Brief 5K is just a fantastic way to involve more people, especially among the youth, and contribute to the fight against colon cancer.
Thank you, Callie. As you all see, they're really good with technology. I mean, they want to start a TikTok account. They want to use the QR codes, and so I'm learning a lot just even working with them in regards to technology. Just to summarize, what we're really trying to do is identify content that resonates with young people, with high school students, right? And then creating some type of collateral, some kind of messaging, infographics, social media posts and whatnot based on that content. And then at the same time, recruiting and having kids join us at the Boxer Brief 5K. There is a high school challenge where HCB2 will be giving money back to the school for certain division winners. So there's kind of a lot going on right now with the junior club, and we're just starting out. We have 15 members from 4 different area high schools. We have Maggie Walker involved. We have Freeman High School, James River High School, Clover Hill, and new is Midlothian High School. So we meet about once a month. If you know of any high school students that would like to receive community service hours and give back and learn a little bit more about colon health and colorectal cancer prevention, please email info@hcb2.org. Thank you so much.
Thank you, Mindy and the Junior Club for, it's very exciting to hear young people, get involved in this work. So I want to remind everyone that if you have comments or questions, please put those in the chat if you can. And we're going to move on to our next presenter, Dr. Davis, on engaging the next generation of healthcare providers.
What an act to follow. You guys are awesome, but I will do my best. So I'm Reed Davis. I'm a third-year internal medicine resident at UVA. I'm going to talk to you about how we try to increase colorectal cancer screening in our resident clinic. So our clinic is called University Medical Associates. We have 90 residents that provide primary care there. About 1,200 patient visits annually. A quarter of our patients are uninsured, 38% are minorities, and 40% are commuting from outside the county to come see us. Our colorectal cancer screening rate in 2019 was around 50%. And kind of why do this study? I think several reasons. One, residents are the doctors of the future. They're impressionable, eager to make changes, and still kind of building their practice habits. And they're going to be on the front lines for the next several decades. Also, resident clinic patients represent the greatest disparities that we see in colorectal cancer screening. Next slide, please. Thank you. So first, we sent out a survey just to see what residents thought about colorectal cancer screening. And the big takeaway here is that few residents believe that stool tests were effective, and few of them offered stool tests as first-line screening, whereas almost everyone believed that colonoscopy was very effective and offered colonoscopy very frequently. And most people did not know that we have a target of 80% of people that we were trying to screen. Next slide, please. So what do? We sought to employ several evidence-based initiatives. The first thing, we did 2 residency-wide educational sessions where we reviewed all the different screening modalities that are available, went over the efficacy, pros and cons, and guideline recommendations that have already been mentioned. We went over who's average risk and can get stool tests and who's high risk and absolutely needs a colonoscopy. We went over our screening goal of 80%, as well as provided individual screening rates to residents. We went over common barriers and disparities in colorectal cancer screening to increase awareness of that as well. We also had resources from the American Cancer Society provided in the clinic, and those are on the next slide. On the left, you can see conversation cards that were put in every clinic room that go over FIT testing and colonoscopy, and these were where patients could read about how tests are done, how often they have to be done, if you have to have prep and things like this. Also, it was a useful guide for doctors and residents to go through with their patients while they're having shared decision-making about the different types of tests. And then on the right, you can see the posters that were put up throughout the clinic, raising awareness for the need for colorectal cancer screening, as well as that the age had been lowered to 45. Next slide, please. So what happened? The amount of stool tests that were ordered increased by over 200%. In 2019, we were ordering about 20 stool tests per month. And in 2021, when we did our educational sessions, that jumped up to about 50 stool tests per month. So we're very, very glad to see that. Next slide, please. Also, in the survey we sent out after our educational sessions, we saw a significant increase in the confidence people had in stool testing. 20% more people reported frequently offering stool tests. And you can see about 40% had believed that FIT tests were effective in reducing mortality. And then Cologuard went from 5 to 68% in people believing that that was effective in reducing colorectal cancer mortality. Next slide. Also during this time, we saw colorectal cancer screening rates improve. And this is even during a pandemic. It went from about 52% in 2019, and now we're up to 56%. So not there, but we're very pleased to see it moving in the right direction. Next slide, please. And our residents know that screening starts at age 45. In our survey, after the educational sessions, 93% believe that it started at age 45, and we share Andy Dwyer's excitement that so many people know about the new guidelines. Next slide, please. So what next? While screening rates improved, we do believe there's a huge opportunity to increase further by getting more people to return their stool test. And we plan to have nurse navigators call patients and troubleshoot with them, as well as sending out letters and MyChart reminders to folks that aren't able to return their stool test. Next slide. So just some overview of lessons that we learned through this. Residents are eager to learn and provide excellent evidence-based preventative care. Knowing colorectal cancer screening targets and personal screening rates is empowering. Education is key to ensuring providers feel comfortable and confident offering a variety of screening modalities to patients. Also, point of care resources help providers in a busy, low resource clinic. Colorectal cancer screening rates can improve even during a pandemic. And lastly, the best test is the one that gets done. Next slide, please. And then I just want to say thank you to my team, who's been incredibly supportive and provided wonderful mentorship. Thank you.
All right, thank you. So let me just say that I want to thank everyone for their presentation. We're going to stay on past the 2 o'clock hour just to make sure that we get questions and answers from the audience. One of the things that I would like to do next is to, I guess, provide to our audience something that our Virginia Colorectal Cancer Roundtable has decided to do an inaugural Impact Award for this year. And we have our Virginia Colorectal Cancer Roundtable Colorectal Cancer Champion Award given to the person who has been the example of someone who has championed this type of work for a number of years, but in particular the past year. So this Impact Award for 2022 goes to, and you can give a virtual applause once, you know, our very own Dr. Alex Chris. And so we want to give him a virtual applause for the work he has done in this field. And you'll receive a nice gift basket and plaque for you know, the work that you've done around colorectal cancer. So we're going to move on and say thank you again and move on to our question session for today. So if you have any questions, I know there are some questions in the chat. I'm not sure if those questions have been answered, but Jen, how do you want to handle the Q&A piece? to make sure people come off mute.
Well, I can see that Mindy has her hand up, so maybe we start with that.
Okay.
I
All right,
didn't.
thank you.
Yeah, I apologize. I didn't answer one of the questions in the chat because I thought it would be great for the students to answer. Dr. Cynthia Romero had asked if the students had seen any difference or how how their peers actually received some of the information. So why don't we just go around the horn? Callie, we'll start with you. Have you been able to chat at all with some of your peers that are not on the junior board, and how did they receive the information?
Yeah, I think most of them have been pretty excited. I think especially like I'm on the track team, so a lot of my friends are excited about the 5K to run. But yeah, I think like the one hard thing about like getting our stuff out is with like the flyers. Sometimes people in the halls will just like walk by stuff without looking. But I think social media is definitely really effective. Like we can repost stuff and everyone looks at that. So yeah, it's been pretty positive.
Great, thank you. How about Charlotte and Eva and Juliet?
I would say yes, getting the awareness out about sort of like changing your daily activity and what you eat to prevent, poor gut. I would say it's been pretty effective. However, a lot of teens find themselves enjoying some of the foods that aren't as good for your gut. And so I think informing them about the gut health and the proper, drinking water and the correct fruits and vegetables to eat, I think they understand it. However, I'm not sure if it's very effective towards some of the younger generation, but I think we're still getting the word out effectively.
I think it's also very eye-opening to them. Like I would say most teenagers don't even know what colon cancer is until they see these posters and they're like, oh gosh, I need to like make sure I'm taking care of my gut now to help like my skin health, mental health, physical health, obviously, but also in the future to keep it healthy and safe.
What about real quickly, Sue John over at Clover Hill High School? Have you had any success yet, or have you attempted as you're making infographics?
Just telling my friends like verbally about the effects of a poor diet and especially like junk food, the effect that they can have on the gut, and then making them aware of things like colorectal cancer. They're very receptive to the information, I would say. So as the message gets out, I think that we'll definitely see more teens getting involved with their colon's health.
Great. Thank you so much, y'all.
And I see that Dr. Jones has his hand up, so maybe he would like to ask a question or answer a question.
Well, I just wanted to, first of all, make a shout out. I mean, after this symposium, there's no question why the only state that screens more of its population than Kentucky that we touch is Virginia, because you guys are doing a great job and you guys are really planning for the future by involving your youth. Because what we have to do is make the message around colon cancer a lot like the message around breast cancer. It needs to become lifelong learning for people. And we didn't really talk about genetics very much in family history, but we have powerful tools now to help understand what important family histories really mean for people. And likewise, I think the other key piece is if you want to find those high-risk people, you've got to start talking to them well in advance of 40. And if for sporadic disease, and again, most sporadic colon cancer, young colon cancer, comes with people with no family history. So educating about symptoms, knowing what to do if you have them. We cannot start that educational process early enough because it takes many message deliveries to change behavioral patterns. And so I'm just so impressed with the group that Mindy's bringing together and with the entire Virginia organization to focus on this, because your future in CRC is going to be driven by how you manage this slow motion epidemic of early age onset colon cancer. So just great work to you guys. I'm so impressed. Well done. A lot of ideas I'm going to take home.
Thank you.
All right. Thank you.
Yeah, I was going to say there's a couple of questions.
Any questions? Okay. Can you read those out there, Jen?
Sure, I'd be happy to. I was trying to start at the highest point up. And so we have a question from Jackie specifically for Dr. Jones. And she says that she's thrilled to see a communication approach targeting life course, and her population of interest for EOCRC life course prevention are emerging adults 18 to 25. And she was wondering if you had any data pertaining to communication reach for that group.
So I don't have any data, but I will tell you on the 2 digital campaigns that we're sponsoring, the last one was in Appalachia. We did about 3.5 million small screen messages. So these would be banner ads on your phone, because that's how young people communicate, right? We got to go where they are. And right now we're in the process of over 7.5 million messages in the Metro Louisville and Southern Indiana. So we don't tend to spend as much on the evaluation piece, but we do know that we have almost a double click-through and open rate as our standards in healthcare for hospitals and other things. So we have not been, this is really more of a proof of concept that we can get people to open our ads, and then we'll work on that messaging piece and the data piece later. But your organization, like mine, is very lean and bare bones, and we don't have massive budgets to do massive surveys, which cost a ton. So, but that's a great question. And again, I think the key thing about messaging younger people is because of social media and the digitalization, we can reach them more effectively through a variety of platforms than we could 15 years ago trying to reach 50-year-olds and above.
Okay, and I'm also
Thank
looking
you.
for hands. So if anybody wants to speak out loud, raise a hand. So I think some of the questions in the chat have already been answered. So I'm jumping down a little bit. And Chris says the info on health disparities being taken out equalize the outcome of Black communities to white ones. Where do I find this? So I think she's addressing a specific point that was presented.
Yeah, I was going to say that's in the U.S. Preventive Services Task Force recommendation. There's a section in there, and I posted my email there. I'm happy to send things to people. And with the recommendation, there's a link to the systematic review. It's a 450-page document of all of the evidence. It talks about the modeling and all of the studies and evidence that's there. So it's more than anyone could ever want. I did very much summarize it in kind of that very simple sentence with kind of finding the disparities around access to screening, quality of screening, time from screening or from diagnosis to treatment, and quality of treatment. It doesn't say it quite that clearly in the task force recommendations, but that's essentially what it's getting down to.
All right, thank you. Anyone else? You can raise your hand or put it in the chat. If not, I would like to thank our panelists, our speakers for today for the wonderful job. We can give them a virtual applause. You can hit the hand clap there. And thank our organizers, Jen, for getting us organized today, and Lindsay, Yoshida, and Regay for the work they've done, Lee as well, and the VCCRT, the Roundtable for Virginia, the efforts they've done, and CASFI. So with that, I don't have anything else. I'll turn it back into the hands of Jen and AACE. Thank you.
Okay, thanks so much. I don't see any other questions, so I think we're going to wrap up. I will be, we'll send out an evaluation for everybody. Probably you'll get it tomorrow to just let us know how the program was. And we greatly appreciate everyone being here. Thank you so much.